Hello, everyone. Welcome to 213, your last semester in nursing school. I know you all are excited about it. Today, we're going to talk about several different topics. We're going to start with safety first. And the first place that I'm going to start you is your module. On your module, there are some directions to where I want you to go, want you to do some exploring, because as a new nurse, as a seasoned nurse on the floor when you are working, you're going to have to find resources for you to figure out things, to look up information, as you already have. With medications, you can go to different places. But anyways, so if I'm going to share the screen and we're going to look at the module. And it is under the folder for this Unit 1 content. So if we look at this complex health concepts, and we're talking about safety. So when we finish up safety, the outcome of learning is upon completion of this module, the student will be able to provide client care in a manner that ensures protection from harm and injury for both the client and the nurse by implementing TJC's National Patient Safety Goals. So that'll be our big topic for this section of safety, and we're going to go into and find those National Patient Safety Goals. Any articles that are listed on here, I encourage you to print them off so that you can have them if that's what you choose. It's highly suggested, so let me just leave it at that. So the big place here, let's start at opening up the Joint Commission resource. I have left you directions, but sometime in your career, you're going to meet people from medicine who come to different facilities to accreditate the facility for safety. And you will be interviewed possibly. So don't run and hide like all of us have done before. So here on this Joint Commission website, it is a good place to go find things about safety. So over here in the corner where it says for nurses, click on that box. I need to learn how to click on the boxes and open up nursing resources. So you're going to see things in here that are pertinent for nursing practice, safety things you've heard about before, I'm sure. We're going to talk about Sentinel Events. We're going to talk about Joint Commission things that they have online. And then we're going to go to the National Patient Safety Goals here in just a minute. But just know that you can come here and you can also search the word safety. And it's going to take you to one way, the National Patient Safety Goals. And the abbreviation that you'll see here a little bit is MPSG. You'll hear me say that. So just be familiarizing yourself with what these are. Why Joint Commission? It is a company that, like I said, goes around and accreditates facilities so they can stay open and function. So I encourage you to download the chapter. The simplified version doesn't give you everything that you need. So this is one thing that I'm going to encourage you to print off, but our PowerPoint is going to go by these slides. So I'm going to use this to talk about National Patient Safety Goals. Why do our patients need to be safe? Think of some things that you already have come in contact with with your patients. You fill out that sheet for falls, and falls is in these goals. So when Joint Commission comes to the hospital, they make sure that, or facility, they make sure that that facility is meeting the criteria and goals for these national patient safety goals. So goal number 1 talks about improving the accuracy of patient identification. We can go back to Nursing 111 and talk about this. But the 2 ways that you have learned in nursing school is identifying your patient as name and date of birth. And of course, we always say you should always check allergies. So that is one goal from the Joint Commission, TJC. And here it says we're going to use 2 patient identifiers when providing care, treatment, and services. And I know in clinical, we've come across a couple of situations where the bracelets didn't exactly match up. They have to match for you to be able to provide the care, safe care for your clients. And the rationale for this goal, and all goals are listed here. Wrong patient errors occur in virtually all stages of diagnosis and treatment. They're not labeled right, the numbers aren't right, we're not going to get what we need to get in a safe manner. The intent of this goal is twofold. First, to reliably identify the individual as the person for whom the service treatment is intended. Second, to match the service or treatment to the individual. Acceptable identifiers may be the individual name as identification number, telephone number, but person-specific identifier, and that is the date of birth. So newborns are, when you did OB, they should have been tagged and had their little wristbands applied to mom and to the child in the room so that child could be identified by the parents. So when Joint Commission comes and they look at these national patient safety goals to see if the facility is meeting criteria, they're going to use these elements, they're called, and they're going to check off their list. So, and they're going to watch how you take care of patients. So I'm going to stop sharing the screen. And what I'm going to do next is we are going to pull up our PowerPoint and go from there. So go to your module, follow the directions for your module. There are directions to go to that Joint Commission, resources for nurses, and something that I want you to look up. It's the do not use list abbreviation. So see if you can find it. If you can't, give it a try or two before you say, well, Ms. McHargue, I can't find that. So we need to see if we can find things so you'll be able to, when you're on your own and I'm not here with you, we can do it all together. I'm going to move my picture so I'm not looking at myself talking. Each year, the Joint Commission revises, updates their national patient safety goals. So I have updated this PowerPoint from last year, and each year consecutively I will do. So we're going to have discussion, and what I mean by discussion, back and forth, and you'll see a place in the under the Unit 1 folder where I'm going to open up a discussion board about safety things. So insights into problems of alarm fatigue, that is one of the articles that you're going to come across on your module. And I want you to read that article. It's very important because when you are working in critical care, one of the biggest things is it is noisy and it's loud and there's lots of alarms going on and off. So this article brings you information about how nurses and other people who work in critical care, emergency rooms, or in specialized areas take care of those alarms by not getting fatigued by the constant noises and not tuning them out either. So the Joint Commission resources for nurse, you can find the National Patient Safety Goals there. And there's also on your module a link to just the National Patient Safety Goals. So just follow the instructions, and I would encourage you to print them off so you can look at them. There's another article, A Culture of Safety, and it is on the ANA website. There is a link on your module to that. It's an article by Jones and Carpinelli. The ANA calls for a culture of safety in healthcare settings. There's a book out. I know it's not necessary for you to read it, but you need to know about this book. The Institute of Medicine has written "To Err is Human." We all make mistakes, and you are at some point in your career going to make mistakes, and how you handle them and the response that you handle is going to depend the outcome. So the next article is harm from alarm fatigue, and that is something else I want you to read, such as going back to the ANA website, calls for culture of safety. So where does the National Patient Safety Goals apply to? At the bottom of your slide, you will see that these National Patient Safety Goals apply to the ambulatory areas, behavioral health care areas, critical access areas to the hospital, critical care and the emergency room, home care, hospitals in general, laboratories. Everything needs to be labeled appropriately. And when you go into clinicals at times, you're going to hear the lab call back and say, hey, I didn't get a label for this specimen. Somebody needs to come identify and label it. It happens. Nursing care centers and office-based surgery centers. So going to the next slide. The National Patient Safety Goals were developed in 2002 by the Joint Commission. You'll hear them called TJC. And most of the time when people mentions the Joint Commission, it's in every third year they come around to the facilities to accreditate them. People just get nervous and worried, but if you are practicing the way that you need to practice, you should be good. Each year, TJC gathers information about emerging patient safety issues from widely recognized experts in order to help accreditate organizations address specific areas of concerns related to patient safety. I'm going to talk about those, but the purpose of National Patient Safety Goals is to improve the patient safety. So think of some things and jot them down in your notes. Remember, you can lift the slide and put your notes here, but think of areas where you've already come in contact with some safety things. One of the ones that I'm going to mention to you is name and date of birth, falls, because you fill out the falls report papers on your patient and you give them a score. So think of some other areas that may apply to your patient. The goals focus on problems in healthcare for safety and how to solve them. So back in this time frame, back to 2002, suicide prevention resources. This has been a huge area of concern for facilities, and how you take care of patients that are on suicide risk. They get a sitter, somebody to sit with them one-on-one. Then you're going to have your look-alike, sound-alike drug list. You found those in 117 long time ago. So pull those out and be familiar with those. And then you're going to find from me, according to the directions on your module, the do not use list of abbreviations. How you write an order that a physician gives you can be misread by pharmacy or misread by someone else. So you have to be familiar with the abbreviations that you're going to be using while you're in practice. Reduce the likelihood of patient harm associated with the use of anticoagulant therapy. This is one that's not new, but newer on the higher priority list of things that they are doing. And we're going to talk about it as well. So National Patient Safety Goal, we've already identified this one. We've already talked about it a little bit. Identifies the patient correctly. And how do we do that? Name and date of birth. That should automatically fall out your mouth. And then you identify allergies. So 2 ways to identify a patient. And those are there. And yes, you should know those by now and remember them forever and ever. Patient identification, make sure that the correct patient gets the correct blood, correct medicines, blood transfusions. Why so necessary for blood? And your answer should be, because remember back last semester in Nursing 211, we talked about immunity, and we talked about cytotoxic reactions in the immune system. So if you give someone the wrong type of blood, then you're going to cause that particular type of reaction to their body, possibly killing them. So there is a process that goes on when you are typing and crossing or typing and holding a unit of blood. So if you, the nurse, are drawing the blood specimen, you are labeling the specimen at the bedside by identifying the patient, name and date of birth, and then you are going to write the information on the bracelet that you're going to attach part of that to the tube, the vacutainer of their blood, and you're going to identify it and fill out the paperwork, and you're going to take it downstairs, or someone's going to take it downstairs for you, and they're going to correctly identify it into the blood bank, sign it in, clock it in, and they're going to take this blood vacutainer and they're going to type and cross John Smith's blood with another unit of blood that could be compatible or should be compatible for this client. So once all that process is done, in an emergency, O negative blood can be given, but if we're typing and crossing and we're going to transfuse and we have time to appropriately type and cross the patient for their blood type, you have to identify what John Smith's blood type is. Is it A positive? Is it A negative? B, AB, or what type? And once that it's identified, then they can get a unit of blood out of the refrigerator that's, say John Smith's blood is A negative. So they're going to go to their blood bank cooler and they're going to pull out a donated unit of A negative. Then they have to take a piece of the ribbon from the tubing off of that, and they have to type and cross match John Smith's blood with that A negative blood from the cooler. Lots of steps, big, huge steps. And this is one of the reasons that State Board of Nursing says no students can give blood, because there's lots of things to look at. If you are in clinical and you have the opportunity to go with another nurse or faculty member to pick up a unit of blood, then it's worth observing so you have some kind of idea, so that when you're in practice, you'll know what to do. And then once that unit of blood is compatible with John Smith's A negative blood, then the blood bank will call you, the nurse, and say, hey, Mr. Smith's unit of blood is ready. So you go down to the blood bank, and the lab personnel has the information in their hands or on the computer, and you're looking at the information, making sure that it is correct. And as long as there are no mistakes, they're going to hand you that unit of blood. There are numbers they're going to read you. There's medical record numbers they're going to read you, all kinds of other numbers. And once you've verified that that is the correct unit, correct patient, you're going to take that unit of blood back upstairs where you were, the floor that you were working on, John Smith's room, and you're going to get a colleague and you're going to say, hey, I need to give Mr. Smith this unit of blood. Can you come help me identify the identifiers, or come help me check this unit of blood? So you're going to go to the patient's bedside and you're going to do those numbers all over again. So important thing is identifying the correct patient for the correct treatment, correct blood, and blood transfusion. Lots of things. So a goal, and the second goal, is to improve the effectiveness of communication among caregivers. It's not just you taking care of the patient. You have a collaboration of other folks that are helping take care of this client. You have respiratory therapy, you have healthcare providers, you have physician's assistants, you have lab personnel, lots of folks. And most facilities have a time frame of notifying healthcare provider, labs, diagnostic procedures, and other data pertinent to patient care. So you're taking care of John Smith in the critical care unit, and lab calls you back and says to you, okay, so I have a CBC and a chemistry. I've just printed an EHR. I need you to look at it. John Smith has some critical lab values. So you're in the middle of something and you go back to finish what you're in the middle of. The hospital has a policy, and that policy says you need to notify the healthcare provider or whomever's taking care of his client in a certain amount of time. I know, because I've worked at Ardell before, that in critical care, the time frame is 30 minutes. Some facilities may be less or a little more, but that time frame is very important according to TJC, according to taking care of the patient, and pertinent things for this client. So if you have a client, John Smith, he had a CBC done and his hemoglobin is 3.1. What are you going to do? You got to call the healthcare provider. You got to stop, if you can stop what you were in the middle of doing, and say, hey, Dr. So-and-so, I have John Smith in room 201 and Mr. Smith's hemoglobin is 3.1. And they're going to go, wow, maybe. And they're going to say, well, we need to type across Mr. Smith for some blood. So you're going to take care of that, just like we were talking about in the goal one. So just remember that time frame is very, very important for care of your client, making sure that things are safe and they're getting the safe care that they need for labs, diagnostic procedures, and any data that's pertinent to patient care. Improving communication, so those critical results of tests and diagnostic procedures on a timely basis. Most facilities are in that 30-mark window. So just remember, and down here it says, this goal applies to critical access hospitals, all hospitals, and all laboratories. Think of your clients that we send specimens to that we're doing a wound culture. You're going to find clients all over the hospital, but you're going to find people that in critical care as well, they're going to have wounds. You have to measure them. You have to document them each individually. And you are going, if they're nasty enough, you're going to have to culture them and send that down, and they have to be labeled correctly. So we're going to build on these things that are going to be safe for the client. So goal number 3, medication safety. We have learned this from day 117 said, before you give any medicines, you have to check that bracelet, you have to look at that bracelet, and you have to identify the name and date of birth, and do you have any allergies? Improve the safety of given medications. So the other thing that this goal speaks about is labeling all medications, medication containers, and other solutions on or off the sterile field in a perioperative or other procedural area. So we have a client in endo, or they're doing an endo at the bedside, and they decide, if it's an endoscopy, that they're going to take a specimen and biopsy the stomach or wherever, duodenal, whatever area. We have to make sure that that specimen is labeled correctly. You will find in the facilities, and Joint Commission will watch this when they come in, to make sure that you are not mixing medications in an area that's not clean. If it needs to be sterile, you need to be in a sterile field. Pharmacy has to mix certain medications under the hood, and it has to be made sure that when they're mixing it, they got proper ventilation. So another goal with patient safety. So here is this anticoagulant. It goes along with National Patient Safety Goal 3, but this is 0.3.05. Reduce the likelihood of a patient getting harmed associated with the use of anticoagulant therapy. How many anticoagulants have you ever given? Coumadin, warfarin, Arixtra. I think of some other medications that you've given in the past, Lovenox. And these medications, you have to make sure that these patients are being properly monitored when they're getting anticoagulants. In critical care and sometimes on telemetry, you're going to see heparin drips, and they're going to be, patients are going to have labs drawn to make sure that they're inside a therapeutic range to know that they're getting the proper amount of medication so they can be properly safely anticoagulated. So in 2021, Joint Commission made this National Patient Safety Goal a higher priority on their list. So there has to be approved protocols according to evidence-based practice research for reversible agents on anticoagulants. So think of your reversible agents for heparin, protamine sulfate. Think of your other reversible agents for other anticoagulants. So in your notes section of this slide, put your anticoagulants and put beside of it the reversible agents that they would need. So as you're going along your busy day in critical care, taking care of 2 or 3 clients that are very, very sick, you have to know in your mind, okay, so my patient's on heparin drip. If they're outside the therapeutic range and we're monitoring their PTT, then I need to know what to do for this client if they start bleeding or if things aren't going the way they need to go safely. So think of all your anticoagulants you've given in the past, and then write down beside of it your reversal agents for them. In a perioperative management for bridging medications, timing for stopping anticoagulants, and timing and dosing for restarting anticoagulants. So think about your patients that you take care of on 5 North, your hips, your knees, your spines. They have to stop anticoagulants before they can have surgery. So in your notes section, write down Coumadin. I have to stop taking Coumadin in what time frame before that client can have surgery. So preoperatively, this client is coming in to be managed so they can ask questions. What medicines are you on? And the client says, well, I've been taking Coumadin forever because for whatever reason. And we have to check a lab. They're probably going to be PTs for Coumadin, labs to know, and the lab level comes back astronomically high, say 3 or 4. So what are we going to do for this client to safely get them to surgery if they have to go emergently? So these folks can get fresh frozen plasma, they can get other blood products to close that anticoagulant time, or they have to wait. So these are the things that Joint Commission says we have to watch out for. So there has to be a hospital policy addressing the need for baseline and ongoing laboratory tests to monitor and adjust anticoagulant therapy. So I'm going to give you 2, and I want you to look up your other anticoagulants that you've written down. So Coumadin, we have to monitor PT. What is the antidote to Coumadin? Vitamin K. So we would have to give them some vitamin K to get them back in the therapeutic range for them to be able to go to surgery, or they would have to have some sort of blood product. So if I'm getting heparin, what am I monitoring, and what is the antidote for heparin? So these are the ways and the things that you'll remember them. If you have to look up these things, then you're going to commit them to memory. So hospitals have to provide education to patients and families specific to the anticoagulation medication prescribed. So you're going to send a client home on Coumadin after they've had a knee surgery or after they've had a hip surgery, or sometimes just any surgery, could be cardiac related, and they need education. So if you've ever assisted in discharging a client, every single patient, no matter if they're on Coumadin or not, are going to be given information about Coumadin and how to take it, when to take it, what you have to monitor, so on and so forth. So just remember those things. Hospital uses only pre-filled syringes, oral unit dose products, or pre-mixed bags with anticoagulants. In critical care, you will see any medication that alters heart rate or blood pressure, drips, I'm going to say 90% of the time are going to be either premixed by pharmacy or they're going to come in a premixed bag. Heparin comes in a premixed bag. So when you see that first bag of heparin, I want you to note how many units of heparin is in that bag and how much is in that bag. So that when you program your pump, you're going to see, which is the next one we're going to talk about, what units per hour is going to be. When you are using pre-filled syringes, what pre-filled syringes have you used in the past? And then when you see them, make a note of it on this slide where it says only the pre-filled syringes, oral unit dosed products, and pre-mixed bags. Hospital uses programmable pumps. Absolutely. You'll see those in Sims Lab. When we do Mitchell Community College critical care, you're going to be programming a pump with another student nurse, as you should always practice 2RN check. Anytime you are programming a pump, just remember, and you can say, Ms. McHargue said this, that if I'm giving a medication that's going to, for anticoagulants, alter heart rate or blood pressure, I need to have a second person look at this to make sure I'm not overdosing or underdosing. The patient is safely getting the correct amount of medication. Very important things to remember for practice. So National Patient Safety Goal Effective 2021, reconciling medication information. We've been reconciling medications for quite some time, and you will see pharmacy, if the patient comes in through the emergency room, grab a hold of them before they go upstairs, or they will get to the client when they get upstairs to go over all medications. Now, let's say we have an elderly client that comes up to critical care, and the reason that they're coming up to critical care is they have altered mental status. Are you going to get all the correct medications, all doses, how often they take it, of the medications they take at home? Probably not. So the medications, and you will, EMS folks can tell you this, that usually what they do is grab medications that are sitting out or in the cabinet for this client, and you can use the data on the information of the prescription bottle, whatnot, and sometimes get that correctly. But the most correct is getting it, knowing where the medicine came from, what pharmacy, and contacting that pharmacy to say, hey, this is Ms. McHargue, and I'm taking care of so-and-so in critical care in bed number 3, and he's being admitted today, and I need to know his medication. Sometimes they'll fax you over a list of medications this client is on, and sometimes they'll just verbally tell you on the phone. They will ask you information pertinent to that client, like their date of birth and some other information that they have that they know that you know, to make sure that you are who you say you are. So this goal focuses on the risk points of medication reconciliation, identifying so that you identify correctly the medication that this client's going to be getting, what they take at home. If they take on a daily basis, they need to continue to take this medicine if it's not going to alter their care while they're in the unit, i.e. blood pressure medicines and heart rates, things like that. But most of the time, these folks need to stay on the medication that they were on prior to the hospital. Reducing the negative patient outcomes associated with medication discrepancies. We want to prevent those. That's what this National Patient Safety Goal is all about, preventing errors. Providing patient education on safe medication and coordinating communication with the client, with other facilities, especially if you have to transfer that client from critical care to a higher level of care or to a different facility when they're ready to be discharged. So think about those things. A lot of thinking to do. Goal number 6, alarm safety. You're going to read some articles about alarm fatigue and alarm safety. Very, very important in critical care. Different things make different alarms, and I can tell you from the years and years that I've worked with students, new people in critical care, when they first walk through those doors, it's overwhelming just to hear all the alarms going off, much less you being the person taking care of that client. Well, what's that alarm mean? Or is it a green alarm, a yellow alarm, a red alarm? How do I know which one to go to take care of them? That's very important. Okay, so we're going to reduce the harm associated with clinical alarms. What are the alarms used for? It's a ventilator, it's a tube feeding, it's a cardiac monitor, it's a blood pressure, it's an A-line. It could be anything. And I need to know what those sounds are. Much less the phone ringing or the family calling to say, well, how's my mama doing? Or how's my daddy doing? How's my brother doing? What's going on? What has the doctor been by? So alarm fatigue is a big one for critical care and for the emergency room and anybody that works with equipment that makes alarms. So it says here, alarm fatigue is the #1 hazard in healthcare. People tune the alarms out. Guilty. I've done it. Sitting right there beside the monitor that's showing off all the cardiac rhythms or for all the patients that I'm working with on that floor. And I'm in the middle of charting and I'm trying to get caught up. I've got this and this to do. I've got meds to give. And that crazy cardiac monitor goes off. Well, if it's a yellow or a red alarm, I need to get up and go check on the patient. I can't just ignore it. But there have been times, and you will see information when you read these articles, that patients are dying because people aren't getting up to go make sure, I'm just going to hit the silence. It'll be okay. Oh, their heart rate's 50. It'll be fine. No, you need to get up and go check on your client. If the alarms are not on, what can happen to the patient? That's a question for you. That we'll have a discussion forum for these. So if you hear an alarm and you go to the bedside, who do you look at first? Or what do you look at first? Do you look at the monitor or do you look at your patient? You better look at your patient, because sometimes what's happening on that monitor doesn't correlate to what's happening to the patient laying there in the bed talking to you, and the monitor says asystole. If somebody's talking to you, normally, hopefully, they're not asystolic. An asystole means there's no rhythm on the monitor. So check your patient first. Look at the monitor simultaneously to see what's going on. Maybe it's just a lead that's come off, because you're going to put 5 different leads when we go to the Mitchell Community College Critical Care. You'll learn how to put leads on, and they do pop off because people move. Special lines and devices. I have an A line, an arterial line, an IV that's in an artery. What can happen if that arterial line comes dislodged or comes out and the person who put it in doesn't suture it in? Think of your arteries, high viscosity areas of movement. Those A lines can slide out and your patient can sanguinate in no time, or you'll see blood squirting in long streams. Can happen. So clinical alarm safety, this just goes back to reiterate that we're going to look at the monitors. We're going to look at the patient first. There's ventilator alarms, there's balloon pump alarms, arterial lines, special devices, tube fittings, telephones, call lights, all kinds of things. We've got to make sure that our patients are safe. So healthcare associated infections, boy, do we not have a new one, coronavirus. We're going to reduce, goal number 7 says, reduce the risk of healthcare associated infections. I have to step away for a second. Let's start back where we left off. Going back to share the screen. Come back. So goal number 7 is we're going to, as a nurse, reduce the risk of healthcare associated infections. So let's say the reason we know why COVID patients are put in one particular area of the hospital, and when you have a COVID patient, you may be taking care of an additional COVID patient. But let's put us on 5 North or the surgical area, and someone has surgery, a joint replacement, a belly surgery, a neck surgery, but surgery in general, we want to keep that client away from other clients that may have some infection going on in their body. What is the number one way to prevent infections? I'm going to go to the bottom of this slide right here, and if I had a pencil, I would circle it or I would highlight it, because hand hygiene is a number one way to keep your other patients from getting what your other patient down the hall may have. So C. diff is a hand hygiene. It is not a gel in and a gel out. The only way to get rid of the C. diff, Clostridium difficile bacteria, is to wash your hands. So coronavirus. So if you are taking care of a COVID patient, you may have other COVID patients, and you may be on an area working where there's nothing but COVID patients. So new era in time, future nurses, of this pandemic of COVID. Catheter-associated urinary tract infections. I think you did a worksheet last semester on CAUTI. If a catheter stays in longer than it needs to, the body recognizes it as something in the body that's not supposed to be there. And think about your clients that are incontinent, not necessarily just elderly, but those females that are incontinent of stool and they have a catheter in. That is a huge setup for CAUTI or urinary tract infection. Central line associated bloodstream infections, eclampsia. You have the privilege, or it's a gold star in critical care, if you have a central line where you can run all your drips, your pressors, your heart medicines. You need a line for the majority of those anyways, a central line, because you can't run them in peripheral lines. It's a gold star to have one. And when you have it, you need to take care of it and keep it clean. And these ventilated patients with a tube down their throat, something's in the body, then the body recognizes it. It's not supposed to be here. So when you have a tube in your throat, what does the body do? It causes an increased amount of saliva, sputum, and you have a central line in this left side of the neck, and the patient's head's tilted that way. Where's that sputum going to roll out the mouth? Right on that central line. So we got to keep that clean. So tilting the head and repositioning is a big thing with central lines. General infection prevention and protocol. You will have manuals online at your facility that are going to tell you if this client has this particular type of infection, there's prevention and control that we need to take care of to safely keep that patient from getting anything else. Multi-drug resistant organisms. We're going to talk about that one here in just a little bit, but think of all the multi-drug resistant organisms that are out there. There's a bunch. Septic clients can become septic from one infection or multiples. And then that wonderful hand hygiene that we're going to always remember. I'm going to wash my hands because I'm keeping myself safe. Not only me, but I'm keeping my other clients safe. Comply with either the current CDC guidelines, hygiene guidelines, and the World Health Organization hand hygiene guidelines. You're going to see on the folks that are in the hospital a sign on their door if they have something, I can't think of what I want to say, something growing, an organism, they're on isolation, there's the word, and it's going to tell you what you're going to do for that client. Do we wash our hands before we put gloves on? Why, sure you do. And you have to dry your hands really, really well to get the gloves on. And do you wash your hands after you take your gloves off? You better, because that's what you're going to be watched, because there are people in the hospital that do nothing other than to make sure you are practicing the way that you practice. Did Miss McHargue wash her hands before she put her gloves on, gel in, gel out, or wash her hands when she came, before she came out of the room? they're doing statistics on this information so that when TJC comes to accreditate your facility, they know that this nurse is doing what she needs to do, or this nurse is doing what he needs to do. So we want to prevent healthcare associated infections. Another thing about that is when a client comes to the hospital on admission, you will answer questions on a nursing history form. And one of those questions is, number one, do they have an infection and what kind do they have? And did you put them on isolation? And what kind of isolation did you put them on? Do they have a wound? Was it there before they came in, or did they develop it while they were at the hospital? So Medicaid and Medicare patients, I learned this when I did administration and I did auditing. When someone comes in with no wounds or no infections and they develop them while they're in the facility, insurance won't pay for them or their hospital stay or them to be there. So just remember that. Multi-resistant drug organisms. On this slide, I want you to pull up the notes section and I want you to list the multi-drug resistant organisms that you have seen personally, and I'll be listing some for you as well. There's going to be that card on outside the patient's room on their door. It's not displayed in a placard big sign anymore. It's a little card that tells you what organism or what type of isolation. So you will learn the different organisms and what different isolations, and there will be a manual you can go to find out which is what. So notes section, part of the work that you're doing as we go through lecture is to pull up the notes and write the multi-drug resistant organisms that you've heard of. You can look up on the CDC, the World Health Organization, Institute of Medicine, any of those multi-drug resistant organisms. How do you get them? How do you get them? Think about that, and that'll be in the discussion forum. Healthcare associated infections related to CLABSIs. We did in 211, we did a worksheet on this. Implement evidence-based practices to prevent central line bloodstream infections. How often are you going to change that dressing? How often are you going to turn that patient? How often are you going to assess that area? Surgical site infections. Implement evidence-based practice for preventing surgical site infections. Implement evidence-based practice to prevent indwelling catheter-associated tract infections, CAUTIs. This is a big one. If a patient comes in, they don't have a Foley catheter, they end up with a Foley catheter because they're sick and in critical care and they're unstable, and they end up with a UTI. That's called a CAUTI. And insurance will not, Medicare, Medicaid, I know for sure, will not pay for their stay. So organizations identify safety risk inherent to certain patient populations. One of the biggest ones is suicide. And back in the early 2000s, it did happen where clients would finish out their suicide attempt while they were at the facility, hang themselves with a sheet or anything like that, wrap cords around their necks. I've seen that in critical care where a client's angry because they were saved from committing suicide and didn't get the proper care that they need, and they would just wrap a cord around their neck. It's not funny, but thinking that they could finish out, but we can get to them and save them a whole lot quicker and get them the care that they need. But identification of the patients coming to the facilities, are they at risk for suicide? On that nursing history, when you do that with a client for the very first time, there's a question on there. You, as the nurse, have to ask the client, have you had thoughts of suicide? And hopefully they'll be honest. And then you can place this client in the appropriate type of care. Universal protocol for preventing wrong site, wrong procedure, wrong person surgery. Well, one of the ways that I have taught this particular thing, if it's not a so said now protocol or a so said rule, It's happened some point or other. Yes, people go to surgery, they have the wrong site surgically prepared, fixed. They have a wrong procedure because they're not appropriately identified, and wrong person. So you have to conduct a pre-procedure verification process. They have to ask particular questions. There is a timeout sheet performed before any procedure is done, and every person in that room, in the OR, has to agree. This is John Smith. He's having an appendectomy, and Dr. Surgeon is doing the procedure. And if it is a site that has multis, fingers, arms, legs, then patient's going to give a surgical pin, and they're going to initial, and then the surgeon has to come back and initial the procedure site. So pre-procedure processes for surgeries or anything else that's being done to a client, hospital should always make sure that the procedure is what the patient needs and is performed by the right person. Pre-procedure verification is an ongoing process of information gathered at any time. You, as the client coming in to get your left knee worked on, they're going to ask you question after question, and you have to be patient. The client has to be patient because they're going to say, well, which leg and which doctor's going to do it? That's so that all this checklist is being done. The purpose is to ensure that all relevant documents and related information or equipment is available, correctly identified, labeled, and matched to what this client is having. You will do procedures in critical care. You'll do endos, you'll do colons, you'll do bronchoscopies. You will put in central lines, you'll put in arterial lines, you'll put in PEG tubes and all kinds of things. So you will go through this process. Pre-procedure verification may occur more than one time and more than one place before the procedures. Missing information or discrepancies are addressed before starting the procedure. If this patient, excuse me, is having a certain procedure and the equipment that is needed is not available, then we abort that procedure at that time until all discrepancies are taken care of. For more information, if you have any other questions about National Patient Safety Goals, I want you to go print out those sheets or save them on your computer so that, excuse me, you can refer back to them. You can find them on the Joint Commission website where we were earlier. Questions to be, if you are ever in practice and you have a question about what's going on with the client, there is a hotline you can call for the standards for what is going on. Is it appropriate or not? So what happens if a patient goes to surgery and they have a surgery that they weren't scheduled for and the proper identification doesn't happen and the pre-procedure checklist isn't done? Sentinel events can happen. What is a sentinel event? A sentinel event is when a patient's safety results in death, permanent harm, or severe temporary harm. Sentinel events are debilitating to both patients and healthcare providers involved. I can't imagine being involved in a sentinel event and causing a death of someone else, because when you are in healthcare, the proper identification and the proper things, if you follow the rules and so said things that you know that you need to do are done, then that prevents harm. You are keeping your clients safe and you safe. You've heard of the phrase CYB, it's CYA as well. TJC works closely with any organization to address sentinel events and to prevent these types of events occurring in the first place. So if you have a sentinel event, it is a lot of paperwork to fill out. And then you have to, administration is going to have to notify the State Board of Nursing in addition to Joint Commission, because Joint Commission is going to come visit your facility that you work at, and you get to sit down and have an interview with the Joint Commission and explain to them why what happened to your client. So TJC works closely with all organizations to address any Sentinel event that happens. So some of the newest Sentinel event alerts, and you can go on TJC's website, and see and research the Sentinel events that have happened. So here is, for instance, I've listed some. Sentinel Event Alert 61, managing the risk of direct oral anticoagulants. Remember, that one's higher on the priority list. Sentinel Event number 60, developing a reporting culture, learning from close calls and hazardous conditions. Bedside report is very, very important, and we're going to learn and work on that this semester as we work through different simulations and different things. You can lay your eyes on that client and go over all the drips that are in that room with the client. And if they are able to talk, they are able to be involved in the report to make sure that the appropriate report is being given on them. So event number 59, physical and verbal violence against healthcare workers. This one has evolved over time while I've been in practice. And you may, some of you may have experienced violence from patients before. Yes, I have been in situations where we have had to call security to get them involved and keeping people from hurting themselves. And right before I left to come start teaching, I got socked in the eye by a client who was confused. That's questionable in my book. And luckily I wasn't standing close enough to the person and didn't get hurt. It just knocked my glasses off my face, but it stunned me. It made me mad because no one should ever be spit on, spat on, hit, kicked, anything. But when people get confused, and you're going to see that in critical care, things do happen. Sentinel event number 58, inadequate handoff communication. That goes back to bedside report, and the appropriate information is given during report time. Used to be many, many moons ago, when I first started nursing, you had a cassette recorder and you recorded your report on that cassette. And before you left that day, you handed it off to the oncoming nurse. There was no sit down and talk about the clients for 30 minutes. They wanted you out. So give a report on this cassette recording, hand it over to the nurse coming in, and leave. Not anymore. It's not safe. American Nurses Association information you can get there. One of the articles that you're going to read is the culture of safety. Let me stop here for a second. Not a lot of the information from this safety comes from your book. There's maybe a couple of pages, but this information is very, very important for ongoing practice when you get out on your own. Where am I going to go and where am I going to look? How am I going to look it up? What are the rules TJC says that I have to follow and practice by? Not only them, but State Board of Nursing, American Hospital Association, Will McHargue. There's two. Hinkle and Shever, your med-surg book, there is a little information. It's listed on your module. Just a couple of pages 8 and 432, that talks about safety. Institute of Medicine, you'll find them, IOM.org. Quality Safety Education, QSIN is another place. Joint Commission, that's one of the biggest places that you'll find a lot of this information from these PowerPoints. And then the World Health Organization. So I'm going to stop sharing. And what I'm going to say to you now is you have articles to read. They are required readings. They're not just, okay, I have an assignment on my module, I'm not going to read these. You need to read them because you're going to see this information again. So this is safety, how I'm going to take care of my patients, my clients, my families, so on and so forth. So you may be asked by faculty when you are in clinical, what are you going to do for your client to keep them safe? So you have a confused patient on all these drips and all these things. a ventilator and all these tubes and wires, your central line, your A line, your Foley catheter, how are you going to keep them from pulling it out? How are you going to keep them from getting out of the bed, from falling? That becomes Sentinel events, and that becomes a lot of trouble when you don't do what you're supposed to do. Okay, so this is safety, the concept safety, and you have a module in your folder. You need to go to that module and you need to follow the instructions for different things that I've given you to do, kind of like homework, and read. Do what Ms. Doig said, take that 25 minutes, do a little bit of this at a time. I know there's a lot of work that you have to do, but it's preparing you to be out on your own. Watch the videos. Some of the slides in the notes section has videos to go with it, and I didn't pick anything that was extended amount of time. They're very informative in a 4 or 5 minute video, and I think very interesting. So we'll move on, and this will be the end of the recording for this, and then you'll see it in a discussion forum. So good afternoon, and we're done with safety.